Hi, my name's Alexa Reilly, and today I'll be looking at cases 2 and 4. So to recap, case 2 is based on this image. We see here that the brain has a glioblastoma tumor right here, or a tumor formed from glial cells in the brain. The PET scan on the right shows use of glucose in the glioblastoma-affected brain, and we can see that glucose activity is much higher in the tumor than it is in other areas. So first I'll review the normal uptake of glucose in different tissue types. In normal skeletal muscle, glucose uptake is insulin sensitive, meaning the transporter that carries the glucose will remain inside intracellular vesicles until insulin is present, at which point glucose can be taken up. In the case of skeletal muscle, GLUT4 is the transporter. Similarly, in the normal adipose tissue, glucose uptake is insulin sensitive and glucose is transported by GLUT4. In normal liver tissue, glucose is transported across the plasma membrane by GLUT2 in an insulin-independent manner. And in the normal brain, glucose is transported by GLUT1 and GLUT3, also in an insulin-independent manner. This means that GLUT1 and 3 sit on the surface of brain cells ready to transport glucose regardless of whether or not insulin is present. And here, this image just sort of sums up what I was just explaining. So in insulin-independent transport, like we see here in the liver, the transporter is already sitting on the cell membrane, while in insulin-dependent transport, like we see in the skeletal muscle here, the transporter starts in intracellular vesicles and then goes to the cell surface in response to insulin, which is what this blue thing represents here. And here in this case, we're looking at the brain, and the brain transport system is more similar to the skeletal muscle system in that it is insulin dependent. As you can see from the image, the tumor is taking up more glucose than the surrounding brain tissues. This would be advantageous to the cancerous cells, which rapidly grow and divide and need more energy to fuel this growth than do non-tumor cells. The Warburg effect, which has been observed many times in cancer cells, refers to cancer cells' rapid uptake of glucose for metabolism by glycolysis in order to fuel their high energy demands. One method by which the cancer cells may be able to take up more glucose and more rapidly is by increasing the amount of glucose transporters present, either GLUT1, GLUT3, or both. And this is supported by the paper that I'm showing here, Labak et al., which looked at how the metabolic demands of cancer cells are met, especially in glioblastoma. The article states, in comparing the expression levels of GLUT1 and GLUT3 within brain tumor initiating cells, researchers found a positive increase of 300% from non-brain tumor initiating cells to brain tumor initiating cells in GLUT3 expression, and a lesser increase of 20% in GLUT1. In other words, both GLUT1 and GLUT3 were expressed at higher levels in glioma cells, though GLUT3 in particular was expressed at a much more noticeably increased level. This supports the idea that rapid glucose uptake by cancer cells can be facilitated by increased expression of glucose transporters. So now on to case 4. I'll start with a quick recap. A 2-month-old girl gets jittery a few hours after breastfeeding and sleeps for about 2 hours between feedings. She has only had these symptoms for a short time, even though her diet of breast milk has been consistent her entire life. She has low blood glucose, and administering epinephrine does nothing to increase blood glucose, though it does increase blood lactate. She also has an enlarged liver. After breastfeeding, the girl's blood glucose levels increase, but she cannot maintain these levels in the fasted state. So from this description, I've concluded that the baby has a glycogen storage disease, which was choice 3. And here I have a chart of common symptoms you might expect from each of the potential diagnoses provided in the question, and I'll go through this now. So we'll start with hereditary fructose intolerance. In hereditary fructose intolerance, there is a deficiency of aldolase B. Aldolase B, shown over here, plays an important role in the liver's fructose metabolism by cleaving fructose 1-phosphate to D-glyceraldehyde and dihydroxyacetone phosphate. When absent, the symptoms that result are very similar to the symptoms observed in the case. This includes severe hypoglycemia, lethargy, and an enlarged liver. All of these can occur when fructose is consumed. Vomiting is also another common symptom. Many of these symptoms match those described in the case, but this is not the right diagnosis since these symptoms would all be observed as a direct response to fructose consumption. There isn't a significant amount of fructose in breast milk, so it doesn't really make sense to diagnose this case. We can see in this article by Baker et al. That we expect to see adverse effects due to hereditary fructose intolerance once the child starts consuming more fructose-heavy foods like fruit, like this baby food that I've shown here, rather than as an infant consuming only breast milk. So this is not likely the answer. Now moving on to galactosemia. Galactosemia is defined by an inability to metabolize galactose. We see the pathway here. This can be a result of a deficiency in uridyltransferase, which is over here, or other enzymes in the galactose pathway. Possible symptoms in infants include lethargy, jaundice, unwillingness to eat, poor weight gain, and vomiting. Consuming lactose can also damage the liver, brain, kidneys, and eyes. This seems to be an unlikely explanation for the case, given that the infant in the case only began showing symptoms after 2 months, while a baby consuming any milk containing lactose, like breast milk, would normally show symptoms much earlier on. And now we'll look at glycogen storage disease. And I have a chart of many glycogen storage diseases here. I believe that the glycogen storage disease does account for the observations seen in the case. There are several forms, as you can see, and deficiency of various types of enzymes can lead to glycogen storage disease, though all are inherited disorders that result in some issue with glycogen storage and mobilization. Hypoglycemia is seen in glycogen storage disorder types 0 and 1, which are at the top here. It's a bit hard to read, but we'll zoom in. In both of these, the liver can become enlarged due to increased storage of glycogen. In type 1A, von Goerich's disease, symptoms often don't appear until around 3 months of age, which is fairly in line with the case that we have here, in which the girl doesn't show symptoms for her first 2 months of life. Due to low glucose levels, fatigue and irritability can also occur in people with glycogen storage disease. This irritability relates to the observed jittery spells, and the fatigue explains the girl sleeping between feedings. Additionally, an important clue was that administering epinephrine caused lactate to increase but blood glucose to remain constant. So normally epinephrine would lead to an increase in glycogenolysis and gluconeogenesis in the liver. So normally glucose 6-phosphate is converted to glucose in response to epinephrine, which increases blood glucose levels. In von Goerich's disease, there is a deficiency of glucose 6-phosphatase, the enzyme that catalyzes this reaction, meaning free glucose cannot be released through glycogenolysis or gluconeogenesis. This leads to the accumulation of pyruvate, which negatively feeds back on the Cori cycle, ultimately meaning less lactate will be converted to pyruvate and lactate levels will increase in response to epinephrine, and you can see that cycle pictured here. The case description also states that the patient's blood glucose levels increase in the fed state. It makes sense that lacking glucose 6-phosphatase would do nothing to change the increase in blood glucose corresponding with feeding, which is directly consuming glucose, but that it would decrease the ability to release glucose into the bloodstream via gluconeogenesis and glycogenolysis. Now looking at option D, which is glucose 6-phosphate dehydrogenase deficiency. This immediately seems unlikely since it's an X chromosome inherited disorder, meaning it's very unlikely to occur in a female patient. In glucose 6-phosphate dehydrogenase deficiency, the oxidative phase of the pentose pathway, which yields ribulose 5-phosphate and NADPH, is interrupted. And we have that a small segment of the pathway illustrated here. Without sufficient NADPH, red blood cells will lyse in response to oxidative pressures. Some resulting symptoms, including fatigue and possibly enlarged liver, are similar to those observed in the case. There are other symptoms like jaundice, which were not mentioned in this case. In this condition, I would not expect to see the effect of epinephrine administration that was described in the case. An issue with glucose 6-phosphate dehydrogenase, or a deficiency of that enzyme, would not make lactate generated by the Cori cycle accumulate like we saw in the case. Ultimately, a glucose 6-phosphate dehydrogenase deficiency doesn't seem like the best explanation for the observed symptoms. Choice C, glycogen storage disease, and particularly type 1A glycogen storage disease, is the most likely cause of the symptoms in the case. So that's all I have for you, and thank you for your time.